Hi, I'm Dr. Tracey Marks, a psychiatrist, and I make mental health education videos. Today I'm answering a viewer question from Mr. R. Hi, Dr. Marks. Could you please make a video on how to differentiate between the negative symptoms of schizophrenia and major depression with psychotic features, and the difference in treatment? Thank you, Mr. R, for your question. There's definitely some overlap between the negative symptoms of schizophrenia and the depressive symptoms in a person who has depression with psychosis. First, let me define negative versus positive symptoms. Negative symptoms were described by Eugen Bleuler. He was a Swiss psychiatrist who first introduced the term schizophrenia in the early 1900s. Before he came on the scene, what we now know as schizophrenia was called dementia praecox, or praecox as some people pronounce it. It was thought of as a dementing illness because of the effect that it has on your thinking and problem solving. I have a video talking in more detail about schizophrenia that you can watch after this video. The dementia aspect of schizophrenia is important because the cognitive decline that you get with schizophrenia is one of the hallmark differences between that illness and the mood disorders like depression or bipolar illness. And the psychosis you get with depression or mania looks different from the psychosis that you see in schizophrenia. So Bleuler came along and expanded our understanding of schizophrenia by introducing the 4 A's: Alogia, Autism, Affective blunting, and Ambivalence. These 4 A's are now called negative symptoms of schizophrenia. They're negative because they're the absence of something. Positive symptoms are additional or extra stuff going on that's not supposed to be there, like delusions, hallucinations, and disorganized thinking or behavior. Let's look more closely at the 4 A's. Alogia is called poverty of speech. Your speech is empty of details, and this is more than having trouble starting conversations. You don't have much to say even if someone asks you a question. In fact, if you're talking to someone with impoverished speech, they may not answer your question. And not because they don't want to, they may have disruptive thoughts that make them not even register the question. Here's an example of how a conversation should go. How are you today? Good. What'd you do today? Not much. Can you give me some more examples of what you did? No. It can be very hard to keep this kind of conversation going, and many people will just give up. If you don't know that the person has a mental illness, it may just look like they're being difficult. Number 2 is autism. Some people call this asociality. It's not the same as autism spectrum disorder. The negative symptom refers to the general concept of being detached from your environment. Because you're consumed with your inner thoughts, you don't relate that well to people. And in the example of the Alogia conversation, there's a disconnect. The person isn't being defiant or shy. They're answering these questions to the best of their ability, and they aren't concerned about how they come across because they don't see the interaction as lacking. The depressed person who doesn't want to talk may look aggravated or sad and communicate with their body language that they don't want to talk. The person with alogia and negative symptom of autism can just matter-of-factly answer questions with one word and appear unfazed. You're the one who's left feeling like you're not connecting. Number 3 is affective blunting. This refers to a restricted emotional expression. Usually when we express emotion, we smile if we're happy, we frown if we're sad, or we scowl if we're angry. And you can see this range of expression in your face, your eyes, your forehead, body position, and tone of voice. Reading someone's facial expressions and body language is instinctual. We're not given a cheat sheet that defines what facial expressions mean. We learn over time by associating what someone's face looks like in relation to what they're saying. We learn to match expressions, voice tone, and speech content. So with affective blunting, you have a limited range of emotional expression as well as a mismatch of expression. If I have a flattened or blunted affect, I can talk about something and show very little emotion. I can say that I was promoted to supervisor position at work and I got a $10,000 raise. You may say, wow, $10,000, you must be happy about that. And I say, yes, I'm pretty excited. If I was depressed and telling you this, my answer may be, I guess it was nice. It's going to be a lot of work though, and I'm probably going to have to work longer hours, and I don't know if I'm going to do a good job. Do you see the difference? With depression, you have more negativity and pessimism in the answer. With the pure blunting without depression, my answer isn't negative, it's just that my emotional expression doesn't match what I'm saying. I'm telling you about something great that's happening, but the way I express it is flattened. If you're talking with me, you may think, is there a catch here? Am I missing something that makes this not a good thing? And that might prompt you to ask more questions. Then I could start to feel annoyed and say, why are you asking so many questions? Because remember, with schizophrenia, I have trouble giving a lot of details, and I don't want to be grilled. So you say, well, I'm just confused. Is this a good thing? Yes. Well, you don't look happy. I am happy. Here, you were just trying to tell someone about what happened to you, and now the conversation has deteriorated. And this kind of exchange feeds into your desire to stay in your head and socially withdraw. That interchange would look different with the depressed person because it would be more obvious that they're in a low place and it would be easier to know how to respond to them. It's important to point out that you can also get this blunting of emotional expression as a medication side effect, particularly with antidepressants. I have a video talking about this problem. If this happens from a medication, usually your depression has improved and you won't have the psychotic symptoms. The blunting is a standalone problem. The last negative symptom is ambivalence, and it's a little harder to understand. It involves having both positive and negative beliefs about something occurring at the same time. Typically, people who are depressed tend to have more strongly negative feelings, but the sense of not having clarity about how you feel about something can occur in either depression or schizophrenia, so it's an overlapping symptom. Ambivalence can lead to apathy, which is a state of indifference. You don't care much about things or have much interest in things. You're just there. Ambivalence can cause you to be unmotivated and indecisive, and indecision is very common with depression. So how does all this relate to psychotic depression? If your depression becomes really severe, you can become psychotic. The psychotic symptoms you have tend to be more positive symptoms like hallucinations or delusions. The hallucinations are commonly auditory, which is hearing things that aren't there. Then there's visual hallucinations, which is seeing things that aren't there. Delusions are false beliefs. The psychotically depressed person tends to have delusions about being harmed, persecuted, or followed. The delusions can also have a nihilistic theme like everything is senseless, nothing has meaning. The world needs to be completely deconstructed, and I'm going to make that happen. With schizophrenia, the delusions can be bizarre and unrealistic, like a government entity has authorized placing chips in our heads, and that's happening while we sleep. But the person with schizophrenia can also have non-bizarre delusions of being followed or persecuted, similar to the depressed person. So to recap what I've just said, there are negative and positive symptoms. Think of schizophrenia as having negative symptoms always running in the background, with periods of more prominent positive symptoms of delusions, hallucinations, and disorganized speech or behavior. On the other hand, depression can have some negative symptoms, but there is a predominance of pessimistic thinking and sadness that you don't really see with schizophrenia. Psychosis in depression happens when the depression becomes severe and you can get delusions and hallucinations. You don't really get the disorganized speech or behavior that you see with schizophrenia. Once the depression improves, the psychosis goes away. But with schizophrenia, you get lingering negative symptoms like the impoverished speech, even if you're not having delusions or hallucinations. The negative symptoms hang around in schizophrenia, but they don't really hang around in the person with depression. Mr. R also asked about treatment differences. Schizophrenia requires treatment with an antipsychotic. Some antipsychotic medications are better than others at treating the the negative symptoms. Vraylar is one of the newer antipsychotic medications that is supposed to be better at treating the negative symptoms. Other ones are clozapine, olanzapine, and risperidone. If none of these work well enough for you, your doctor may try an antidepressant. I don't think that any of the medications completely resolve the negative symptoms. Skills training is something that can help. You can learn how to better interact with people by establishing proper eye contact or learning to start and maintain conversations. 60% of people with schizophrenia have also gotten depressed, and if this happens, your doctor would add an antidepressant for your depression symptoms. For the person with depression, who is also psychotic, the treatment protocol would be to add an antidepressant and antipsychotic medication at the same time. Then, as you get better, you would taper off the antipsychotic and stay on the antidepressant for longer. A typical time to stay on the antidepressant would be 6 months to a year. I usually recommend a year of treatment. With schizophrenia, though, you need to stay on the antipsychotic to keep the psychotic symptoms under control because the negative symptoms usually stay around to some degree, and the positive symptoms can come and go. Watch this video for more on psychotic depression, and this one for more on schizophrenia. Thanks for watching. See you next time.